Hello my friends, welcome back to Cardiac Academy. In the previous videos, we started our discussion on rhythm and arrhythmias. We talked about arrhythmias of sinus origin, and then we shifted into ectopic rhythms. So in this video, we're gonna finish ectopic rhythms, and then we're gonna get into reentrant arrhythmias. So without further delay, let's get into it. All right, let's talk about supraventricular arrhythmias. So when we talk about supraventricular arrhythmias, of course, we refer to arrhythmias originating above the ventricle, hence supraventricular. And this type of arrhythmia can consist either from a single beat or a sustained rhythm. So when we have this single beat originating at the level of the atria, they're known as a PAC, or a premature atrial complex. Let's see an example. So in this rhythm strip that we have here, we can see that we have normal P waves, and we can see that the rhythm is regular. And all of a sudden, we have a new P wave with a different morphology than the previous ones. And in addition to that, we see that the rhythm becomes irregular because it becomes faster. So the reason we are seeing a P wave with a different morphology than the previous one is because these P waves are originating from somewhere else. So the first two P waves are originating at the level of the SA node, so they share the same morphology and they have their own intrinsic heart rate because they're from the SA node. However, this PAC, this premature atrial complex, it's depolarizing the atria, and then that depolarization is conducting through the ventricles, causing a premature contraction. And that's why we see a QRS following that P wave. Now, if you notice, it's shorter because it happened before the SA node could depolarize. So that means that it's gonna be slightly irregular. However, then it goes back to the normal heart rate because the fourth depolarization is occurring at the level of the SA node. So this is known as a PAC. Likewise, we can have depolarization occurring at the level of the AV node, and in that case, it's called a junctional premature beat. If we look at this example, we can see that in these depolarizations that we're seeing here, they are regular. And they also share a P wave before them, same morphology. So these depolarizations are occurring at the level of the SA node. However, if we look at the previous depolarization, we can see that it's faster and there is no P wave. So that means that it's junctional. How do I know it's junctional and not coming from the ventricles? Because the QRS is narrow. If it was coming from the ventricle, it will be wide. So how can we tell these apart from a junctional escape rhythm or escape beat? So with junctional escape rhythms or beats, there's gonna be sinus arrest. There's gonna be a pause. And then we have the depolarization. In this case, it's happening early. It's a premature beat. So when you see these junctional escape beats or a junctional premature beat, you have to take it into context. If there is a pause, it's a junctional escape beat. If there is no pause, that means it's occurring early, and that's a junctional premature beat. So PACs and junctional premature beats are non-pathological, and they do not require treatment, okay? So if you see a patient with occasional PACs or premature junctional beats, that's okay. You don't have to worry. So far, the arrhythmias that we've discussed are due to enhanced automaticity, and they are known as disorder of impulse formation. Now, in the other hand, we have reentry, and reentry are due to a disorder of impulse transmission. Reentry can be divided into two types, AVRT and AVNRT. AVRT stands for atrioventricular reentrant tachycardia, and AVNRT is atrioventricular nodal reentrant tachycardia, okay? So normally when we have a normal depolarization, everything starts at the SA node. From the SA node, this depolarization travels into the AV node, and there it pauses, goes down through the bundle of His, through the right bundle and left bundle, goes into the Purkinje fibers, and depolarizes the whole ventricle. Now, in AVRT, this depolarization uses the normal conduction pathway. However, once it reaches the Purkinje fibers, it goes back from the ventricle into the atria using an accessory pathway. And we can see that happening here. So it starts here at the SA node, goes into the AV node, travels down normally, and then goes back into the atria using this accessory pathway. Through this accessory pathway, this depolarization can travel back from the ventricle into the atria, and if the SA node is refractory, it can cause its own depolarization through a PAC. Now, once we have that PAC, it can travel again to the AV node, down the ventricles, and then climb again back into the accessory pathway, causing a loop. And in some occasions, this loop can cause the heart rate to go up to 200 to 300 beats per minute. The classic example is Wolff-Parkinson-White syndrome. And in this condition, the pathway is an anatomical pathway called the bundle of Kent. So this type of AVRT we just talked about is known as an orthodromic AVRT. This is the most common type of AVRT, and it uses the normal AV node conduction system. Because it uses the normal AV node conduction system, then we're gonna see a narrow QRS, okay? And occasionally we can also see some retrograde P waves. Because it's using the normal AV node conduction system, then we can use AD node blocking agents to treat this type of arrhythmia, meaning adenosine, beta blockers, or calcium channel blockers. Now, in the other hand, we have antidromic AVRT. In antidromic AVRT, the depolarization is actually going to the ventricles through the accessory pathway and then going back to the atria using the AV node conduction system. Because it's not using the normal AV node conduction system, then the QRS complex is going to look widened. In addition to that, in the case of Wolff-Parkinson-White syndrome, we can actually see a delta wave, which is a slurring of the upstroke of the QRS complex. In a future video, we're going to go in much more detail when we talk about pre-excitation syndromes. In this type of AVRT, it's actually rare to see retrograde P waves, and because it's not using the AV node as the normal pathway, then AV nodal blocking agents are actually contraindicated. If you think about it, if you block the AV node conduction system, then you're forcing this depolarization to go down through the accessory pathway. So in this case, procainamide is actually the drug of choice. Now, there's another type of reentrant arrhythmias that we haven't discussed, is the AVNRT. In this case, instead of having an accessory pathway, this loop gets formed inside the node or near the node, okay? Okay, my friends, let's talk about AVNRT. So here, we have the atria. Here, we have the AV node. And down here, we have the ventricles. And at the level of the AV node, we have a slow pathway and we have a fast pathway. Slow pathway, also known as the alpha pathway. And we have a fast pathway. Also known as the beta pathway. I'm going to establish some things about them. So the slow pathway has a short refractory period. And the fast pathway has a long refractory period. And we'll see what that means in a second. Okay? So we said that there's a fast and short pathway. So that means that when a depolarization occurs at the level of the SA node, it will go to the AV node, and when it goes to the path through the fast pathway, it will just go quickly down to cause a ventricular depolarization. Now, at the same time, this same depolarization that occurs at the level of the SA node is gonna go down the slow pathway. And just as the name says, you're gonna start going down, but slowly. So the fast pathway not only goes quick from the atria to the ventricle, it starts also climbing up the slow pathway. And once it meets the other depolarization, it cancels out that depolarization, okay? So we also said that the slow pathway has a short refractory period. So what does that mean? So it means that it's gonna be faster to be ready to get another depolarization, to conduct another depolarization. So while the fast pathway is still refractory because it has a long refractory period, the slow pathway starts getting ready to get another depolarization. Now let's say that for whatever reason, a PAC occurs, a premature atrial contraction. So that means that that premature atrial contraction is going to be able to start conducting down the slow pathway. Let's see how that happens. So it starts going down the slow pathway. And because the slow pathway is so slow, while it makes that trip, the fast pathway is going to get out of refractory period. And that allows the slow pathway to not only make it down to the ventricles, but to start climbing up the fast pathway. And as you can see, this can cause a loop. And that's how we get a reentrant loop. This causes the atria and the ventricle to continue to depolarize through this loop and can drive the heart rate to go as fast as 200 to 300 beats per minute, okay? So when we see this happening in this fashion, going down the slow pathway and up the fast pathway, is called a slow, fast AVNRT, also known as a anterograde or typical AVNRT. But when this happens the other way around, when it goes down the fast pathway and then up the slow pathway, is called a fast, slow AVNRT, also known as a retrograde or atypical AVNRT, okay? Very good. Let's establish some concepts. So AVNRT is a very common type of arrhythmia, and it can usually be seen in young women. It can be initiated by a PAC or a premature junctional beat. This can occur in healthy hearts, although high intake of alcohol or caffeine can initiate this type of arrhythmia. AVNRT and AVRT both are causes of paroxysmal supraventricular tachycardia and can drive the heart up to heart rates of 150 to 250, even though occasionally can go as high as 300 beats per minute. We can distinguish AVNRT versus AVRT by looking at the RP interval. In the case of AVNRT, the RP interval is going to be less than 70 milliseconds. And in the case of AVRT, it's going to be more than 70 milliseconds. Occasionally, we can see retrograde P waves, especially in lead 2 and 3. And in V1, occasionally we can also see pseudo R waves. And in this case, they're going to look like small blips in the QRS complex, and they represent superimposed P waves, okay? Very good. So here we have different examples of patients with supraventricular tachycardia. So on example A, we can see that it's a regular rhythm with heart rates of 300, 150 beats per minute. But we can't really see any P waves. So the reason is because these P waves are actually hidden within the QRS complex, okay? In example B, we see again tachycardia of 300, 150 beats per minute. However, the QRS complex actually looks wide. So in this case, there's possibly a bundle branch block that is causing this depolarization to go aberrantly through the ventricles, which is a very inefficient way of depolarizing the heart. So because it's so inefficient, it takes long. So that's why we see, that's the reason we see a wide QRS, okay? So this is gonna be introduced later, the concept of aberrancy, but in this case, this is an example of SVT with aberrancy, okay? In example C, we can see some retrograde P waves. We can see them here. And we can actually measure the RP interval. So here we see the R wave, and then we see the P wave right here. So clearly, this RP interval measures more than 70 milliseconds. So in this case, this is AVRT. And in the last example, we see pseudo R waves on V1. We can see them here. And we can again mention the RP interval. So here's the R wave. And here we have the P wave. So it's a very short interval. So the RP interval measures less than 70 milliseconds. So this is an example of AVNRT. Okay, very good. All right, let's finish up strong by discussing a clinical case. So let's read it. A 32-year-old woman who has complained of palpitations in the past is admitted to the hospital via ED with palpitations. She works at the local coffee shop as a barista and is wearing an interesting t-shirt that reads, "Give me coffee or give me death." What does the ECG show? All right, so before we go interpreting the ECG, again, we need to remember to do this in a systematic way, not in an erratic way, okay? So erratic is our mnemonic. I know that we haven't discussed every single one of these letters and what it represents, but I want you to be getting used to reading EKGs following this mnemonic. So we'll do it together, okay? Very good. Okay, my friends, let's interpret this EKG. So, like we said previously, we have our mnemonic erratic. And we're gonna follow this mnemonic so we can interpret this EKG in a systematic way. So first is the E, and the E is just for EKG to make the mnemonic work. Then we have R, and the first R is for rate. So here we look for a QRS that falls in a thicker line, like this one over here. And then we have the next QRS is in between two thick lines. So between QRS and QRS, we have 1.5 big boxes. So in this case, probably easier to just divide 300 by 1.5, and that gives us 200 beats per minute. So for the first R, the first answer for our rate is 200 beats per minute. Then we have rhythm. And for rhythm, there are 5 main questions we need to answer. So the first question is, are there any P waves? So in this case, it's kind of hard to see P waves, but if we look closely, we previously said that occasionally we can see retrograde P waves on lead 2 and 3. And we can actually see retrograde P wave here. And lead 3, there's one here too. And we can also look to V1, in which we can see these pseudo R waves, which also represent P waves. So the first question is yes, we see P waves. Is there a P wave for every QRS? And based on these P waves that we found, we can see multiple. Then we can say yes, there's a P wave for every QRS complex. After that, we look to see whether the rhythm is regular or irregular. And we can see that the distance between QRS and QRS is the same. So this is a regular rhythm, okay? After that, we look at the QRS complex. Is it narrow or wide? And we can see that it's a narrow QRS complex, okay? It's measuring less than 120 milliseconds. And after that, we look to see whether the PR interval is measuring more than 200 milliseconds. In this case, the P waves are actually retrograde, so we can't really assess the PR interval. However, since this is an SVT, it's a fast regular rhythm, we can look for the RP interval. And looking here, I'm gonna zoom in, we can see the QRS is here, and then we have the pseudo R wave here. So here, the RP interval is less than 70 milliseconds. So in this case, this is an AVNRT. But let's go through all of the questions so we are systematic. After we assess the rhythm, we look for the axis. And for the axis, the easiest way, and we're gonna go into much more detail in next videos, we look at lead 1 and we look at AVF. And if they're both upright, that means that's a normal axis, okay? So now we know that then axis is normal. Then T waves, we look to see whether the T wave is more than 50% in between QRS and QRS. However, since this rate is so fast, we can't really assess that. In this case, it will be easier to check the QTC interval. QTC is the corrected QT interval, and this is usually given to us in the EKG paper, okay? And we're gonna go into much more detail in how to assess that in future videos as well. So here we can really say ischemic changes. We look to see whether they are Q waves, whether they are T wave inversions, ST elevations, or ST depressions. And in this EKG, I can't really see any Q waves. I don't see any T wave inversions or ST elevation or ST depressions. So it seems like there is no evidence of ischemic changes. And let's say none. And finally, the chambers, we look to see whether there is any evidence of left ventricular hypertrophy or right ventricular hypertrophy. And in this case, we're gonna go into much more detail there, but I don't see any of the criteria for left ventricular hypertrophy. And as I said, no worries, we're gonna go into much more detail into that. So there are none, okay? Okay, very good, my friends. So in conclusion, we have here SVT. We can say AVNRT versus AVRT. Since we're seeing pseudo R waves on lead V1 at a short RP interval, we can feel pretty confident this is an AVNRT, okay? All right, so just remember, take it easy with the coffee. All right, my friends, that's it. I know this was a long video, but I really do hope you found it useful. If you haven't already, please like, subscribe, share it with your friends, and as always, I'll see you in the next one.